হ্যালো স্টুডেন্টস, ওয়েলকাম টু অল অ্যাবাউট নার্সিং চ্যানেল। সো আজকে এই ভিডিওটিতে আমরা আলোচনা করব সিকেডি অর ক্রনিক কিডনি ডিজিজ। সো হোয়াট ইজ সিকেডি? সো সিকেডি অর ক্রনিক কিডনি ডিজিজ it involves the progressive irreversible loss of kidney function. So basically what happens, so in CKD there is the progressive and irreversible loss of kidney function. So there is a normal function of kidney, that is purification of our blood, formation of urine, so maintenance of acid base balance. So those kind of functions of the kidney which is playing by the kidney, so that functions is became lost, and it is continuously, or it is going to be progressive, means it is going to be deteriorating. So the last stage of kidney failure, end stage kidney disease, which is called ESKD, occurs when the GFR is less than 15 ml per minute. So GFR is glomerular filtration rate. So glomerular filtration rate, which is measured in per minute. So according to the GFR rate, so যদি আমরা দেখি, so stage 1, when it is called when the GFR rate is near about 90 or higher, so that is called the stage 1. Stage 2 is called when the GFR rate is 89 to 60, that is stage 2. Stage 3 is mild to moderate, that is 3A, 3B. 3A is 59 to 45, and 3B is moderate to severe, 44 to 30. And the stage 4 is severe, that is 29 to 15, and stage 5 is kidney failure, that is less than 15. So stage 5 is when the kidney function is completely lost and it is going to be deteriorating, which cannot be reversible, যেটা normally আর ফিরে আসবে না। Okay, when in that condition we have to transplant the kidney, or we have to start the dialysis. So at the stage of stage 5, in that stage we start dialysis. So before that, stage 1, stage 2, stage 3, stage 4, in that stage there is no dialysis. Okay, there is symptomatic management. So all the management which is supportive management, that is going to be done, but at the stage 5, from there the dialysis and transplantation is done. So behind the CKD there is anatomy of kidney, our urinary system. So kidney, we all know that there is two kidney, and which is connected with the ureter with the bladder. And so kidney is composed of millions of nephron. So the parts of the nephron we all know, that is Bowman's capsule, proximal tubule, descending loop of tubule, and the loop of Henle, ascending limb of loop of Henle, and distal tube, and the collecting duct. And collecting duct is connected with the bladder, and the collecting duct is connected with the various nephron. And from the various nephron, by this way the urine formed, and urine came to the collecting duct, and it goes to the bladder. And from the bladder plays a reservoir role. From the bladder, the urine goes to out of the body. So the functions of kidney, so the main functions of kidney is it form our urine, it waste our excrete our waste product, body waste product, it maintain our acid base balance of the body. So besides that, it also secretes the erythropoietin. So besides that, the kidney helps to regulate the body fluid of the regulation of the body fluid and the blood pressure of the body. So how it regulates? So kidney, basically from the kidney there is juxtaglomerular apparatus is there. So when there can be two conditions. One, there can be hypervolemia, there can be hypovolemia condition. Hypervolemia means there is increase in the fluid volume in the blood, and hypovolemia means when the fluid volume is less. So in the condition when there is excess fluid volume, so what happens? So from the renin, there is from the kidney there is secretion of renin hormone. Naturally there is secretion of the renin hormone, which is basically, this renin hormone helps to conversion of angiotensinogen to angiotensin 1. So the angiotensinogen, this secretes from the liver. So from the liver there is normal secretion of the angiotensinogen, and this angiotensinogen is converted into angiotensin 1 by the help of renin. Okay, and this angiotensin 1 helps to convert it into angiotensin 2, and this conversion from the angiotensin 1 to angiotensin 2 is converted through a enzyme which is called ACE, angiotensin converting enzyme, which is secreted from the lungs naturally. So this angiotensin 2, it basically helps, it constrict the arterial vessels wall, and it also secrete the ADH. ADH basically antidiuretic hormone, which is secreted from the posterior pituitary, and this ADH hormone helps in the reabsorption of the water, and it also stimulates the adrenal cortex, and from the adrenal cortex there is secretion of the aldosterone, and this aldosterone helps in the reabsorption of the water. So basically this whole process basically runs when there is condition of the hypovolemia, when there is need for fluid, there is need for fluid. Hypovolemia means there is less fluid, so there is need for fluid in the body. So in that condition this system activated. Okay, so when there is hypervolemia condition, in that case what happens, there is no secretion of the renin. So when there is no secretion of the renin, so there is further conversion from the angiotensin to angiotensin 1. From there the angiotensin 2, that conversion is not happened because there is absence of renin. So if there is absence of renin, there is no conversion of the angiotensin to angiotensin 1. So if there is no angiotensin 1, so the further process not happened. So in that case the reabsorption of the water, all those conditions are not happening, so the fluid volume maintained. So next we are moving to the causes of CKD. So basically the causes are the chronic infections. So if the person is suffering from chronic infections like the diabetes mellitus or any streptococcal infection or AGN, any infection in the nephron or nephritis, so in that condition the person can have developed the problem of CKD. Or like renal obstruction, like if there is any stone in the flow of the urine, or any if there is any tumor in the renal circulation, so in that condition that can provoke the CKD. Exposure to toxin, chemicals, toxins or aminoglycoside, antibiotic and nephrotoxicity drugs. So if the person is exposed to antitoxic drugs and any nephrotoxic drugs or antibiotics or any chemotherapy drugs, so those drugs has a side effect to affect the or destroy the functions of kidney. Next is the chronic infection like diabetes, hypertension. So those disease condition, chronic disease condition, cancer. So those disease condition has a can provoke the CKD. And due to the diabetes, there can be a complication of diabetic nephropathy. Okay, and the polycystic kidney disease. So if there is any multiple cyst in the kidney, so that can also cause CKD. This is the pathophysiology. So due to the etiological factors that leads to decreased GFR function on the glomerular filtration rate. So that leads to hypertrophy of remaining nephrons. So due to the decreased GFR rate, the cells and tissues of the nephron became hypertrophied, or the size of the cells became increased, and that leads to inability to concentrate urine. And when there is increase in size of the nephron, so that leads to the nephron function become compromised, the formation of the urine became hampered, and that leads to further loss of nephron function, and that leads to CKD. So next, going to the signs and symptoms. First is the uremia. Uremia means when there is nitrogenous waste product is much more in the body, that is blood, urea, nitrogen, creatinine, uric acid. So those increase in the blood, so that is called uremia. So that is also seen because from the kidney the nitrogenous waste products are excreted from the body through the kidney. So when the function is become impaired, so all the nitrogenous waste product remain in the body, they become accumulated in the blood, that leads to uremia. Next is the metabolic disturbances like waste product accumulation, which I already told, that nitrogenous waste product, uric acid, urea, creatinine. So those products became retained into the body due to the loss of kidney function. Next is altered carbohydrate metabolism. So due to the uremia condition, our gut or our GI tract, in the GI tract there is secretion of the enzyme become hampered. So that leads to altered carbohydrate metabolism, and as well as due to the uremia condition, the insulin production and the metabolism of the insulin that became compromised. So that leads to carbohydrate metabolism become altered. and there is due to the uremia condition from the liver, there is increased secretion of the triglyceride or the LDL level. So increase LDL level or cholesterol level in the patient. Then electrolyte and acid base balance became imbalanced because from the kidney maintain the acid base balance of the body by excreting the nitrogenous waste product and by secreting the H plus ion and the bicarbonate. So it helps to maintain the acid base balance. So when there is compromise in the kidney function, so that leads to imbalance in the acid base balance. Is the hematology system, anemia, bleeding tendency, so that can be seen because from the kidney there is normal secretion of the erythropoietin, or erythropoietin helps in the production of our red blood cell. So when there is less production of the erythropoietin, so that leads to anemia. Next sign and symptoms are hypertension can be seen because due to the there is less excretion of the fluid from the body, so fluid become retained into the body. There is a sign of edema because fluid are not excrete out from the body because kidney are not functioning. So kidney helps to excrete out the fluid from the body. So fluid become retained into the body, and that leads to increase the pressure, blood pressure, as well as the edema. That can lead to heart failure also, and pulmonary edema, pneumonia, and as well as the normal symptoms from the GI tract, that is anorexia, nausea, vomiting, gastritis. Common symptoms can be seen. So next is the diagnostic test. So first is history taking and physical examination should be done. History should be taken from the patient and patient family member, like if there is any infection, chronic infection, other any disease condition is present or not. So those type of history should be collected from the patient, or any history of family history of CKD. So those kind of history should be taken. Any exposure to the chemical toxic chemicals recently. So those kind of information should be taken. Next, the renal ultrasound or UAC should be done to identify, and the renal scan we can do, CT scan, renal biopsy, as well as the blood urea nitrogen level, serum creatinine level should be checked. Next is the medical management. So first we have to correct the fluid volume. So we have to administer the loop diuretics or any diuretics to thiazide diuretics, or we can give the loop diuretics. So both diuretics function is to reduce or excrete the excess fluid from the body. As well as we have to maintain the nutritional therapy, like low protein diet should be provided because from the protein there is excess production of nitrogenous waste product. So if the person who is suffering from CKD, so there is increase in nitrogenous waste product in the body. So if the person is taking protein, so that increased protein in his or her dietary pattern, so protein provokes or protein generate nitrogenous waste product much more. So that leads to increased blood urea nitrogen and creatinine also. And we have to restrict the sodium phosphate level, and the potassium range should be maintained because those electrolytes are not excreted from the body, those retain into the body. So that's why we have to restrict those sodium phosphate level. Then we have to provide a DASH diet, dietary allowances to stop hypertensive diet should be given. Anti-hypertensive diet should be given to the patient because patient has the chances to develop hypertension. As well as you have to start the erythropoietin therapy to manage the anemia, and calcium supplementation should be given to the patient because there is lack of calcium absorption in the gut, in the intestine, in the CKD patient. So we have to supplement the calcium. Next, the dialysis. Next, in stage 5, the best management is dialysis. So you have to start for dialysis. So dialysis basically helps to move the excess fluid and molecules from the blood of the patient to the dialyzer solution. So basically dialysis, this process focuses on 3 principles, that is diffusion, osmosis and ultrafiltration. Diffusion we all know, that is it helps to move the solute from an area of greater concentration to an area of lesser concentration. Means when there is in the blood of the patient there is increased concentration of the blood urea nitrogen waste product is much more in the patient's blood, where in the dialyzer solution there is less concentration of the waste product. So in the diffusion process, in that process what happens, naturally from the higher concentration the molecules or the solutes which is termed as drabo, which automatically move from the higher concentration to the lower concentration. And next principle is osmosis. So from the lesser concentration of the solute, the movement of fluid from the lesser to the greater side it happens. Means in osmosis there is no movement of solute, there is movement of solvent. So fluid is moved from the lesser concentration to the greater concentration. So there is a difference between diffusion and osmosis. In the diffusion, where the movement of solute is done and the solute is moved from the higher concentration to the lower concentration, but in the osmosis there is movement of fluid from the lesser concentration to the higher concentration by or through a semi permeable membrane. Okay, and there is ultrafiltration is there. So by maintaining these three principles, two types of dialysis are there: peritoneal dialysis and the hemodialysis. So in the peritoneal dialysis, this process is time consuming and there is 3 cycles are there. So that should be discussed in next class. So the nurse's responsibility. So the nurse's responsibility basically is we have to maintain the cycle in a strict aseptic technique in case of hemodialysis patient. Vital signs, weight, intake and output chart should be maintained. Laboratory values should be checked before and after the process, after hemodialysis, and assess the skin turgor mucous membranes to evaluate the fluid status and monitor the patient for edema. So next, this is the hemodialysis, so that should be discussed in next class.